Thank you, Richard, and thanks today for all of the speakers and yesterday and all of you for coming. We thought we'd end up with just having a bit of a roundtable discussion centred around Callum, Helen and Peter, but kind of a free-for-all really. As I say, one of the things about the network is that when we wrote the bid for the network, this is myself, Paul Diggard and the other directors involved in the network, is that we were very conscious that many of the lessons that we already knew about coronaviruses or outbreaks had not been applied to SARS-CoV-2. And so we very much centred our bid around, well, this happened in the animal world and it was never applied to human coronaviruses. And also we missed out a lot of side on social science that we've subsequently brought into the network as well. And one of the things that we like to do is write down a list of things that we wish we had done, or things that might be useful for the future, or gaps in research that we think are important, particularly for you guys at the moment working on feline coronaviruses, and everyone is happily stuffing their cats full of molnupiravir or other antivirals. Now, if these were antimicrobials, we would be very worried about that because of antimicrobial resistance, right? And, you know, one can imagine a scenario where you've got SARS-CoV-2 in your cat, potentially, and you're stuffing it full of molnupiravir or remdesivir or whatever. So, again, a fairly wide-ranging discussion, but kind of starting with Peter, Callum, and Helen. So if the three of you would like to sit in the hot seats, I will be the facilitator. I love that word. Yeah, so I'd also like to start by really thanking Peter for his help and expertise in arranging this meeting in Cyprus, and obviously, as well, because Stavros Malas, who we introduced yesterday, I've known Stavros since I was an undergraduate. We have a long and shared history together, and when I broached this to him after Lucy mentioned it, he said, "You must talk to Peter." And when I got to speaking to Peter, it was like I was talking to Callum in terms of commonality. So I'll start with a question, and then we'll open it up to more questions. So, Peter, at the start of the outbreak, what do you wish you would have done? Like, what should you have done with the benefit of hindsight, if you had a crystal ball?
Yes, I think although early on the director of medical services in the ministry said to me, "You will be ideal for informing people," together with 2-3 others on the group, including Stella's mother, who's a pediatrician and was on the advisory committee too. We took it upon ourselves to inform the public, but although we used to go to the meetings with the president and the ministers, they used to say to us, "You're not allowed to say anything of what was discussed here until we make it public ourselves." Of course, when the minister was announcing the measures, he did not inform the people for what reason those measures were being introduced. It was a dry presentation without this justification or anything. And then when we were coming on, when the reporters were asking us, we couldn't dictate to them what sort of questions they would ask of us to explain things. If we try to sidetrack, they will change the topic. So a lot of the complaints I got from the people was that you've never explained to us in detail or in simple terms why those measures were necessary.
Okay, thank you. Helen, your crystal ball.
My crystal ball. So I think we're always stuck with a really difficult position when you've got any new emerging disease. And whether it's in animals or whether it's in humans, there are some standard things that we need to understand to be able to move forward. So you've got to understand the epidemiology, the transmission routes. I find it extraordinary that we still don't know the infectious dose for humans with COVID. And therefore, how do you prevent infection happening? You don't necessarily have to completely negate it, but just to mitigate it enough. What are the potential control measures that you can use, that you can influence? What we were really bad at doing, and we still are not great at it, is understanding social behaviour. And SAGE did bring, thankfully, a lot of social behaviour experts in to be one of those expert groups. But we still are not very good at doing it, even for animal health infections, never mind the zoonotic ones. And people will do weird things, and we need to just accept that and understand what those weird things could be. So having a broader understanding about some of that behaviour, some of the controls that you can put in place reasonably and that people will accept, I think we'll have learnt lessons from COVID, certainly. And we always say that we would never ask the country to completely lock down again. I don't think we should ever say never. It could still be important that we have regional lockdowns. But again, we learnt this from the animal health side. FMD 2001, where we locked down the whole country, too late. It had already gone everywhere. But we still locked down the whole country, and now we recognise actually you'd probably just do regional lockdowns and track the disease as it goes. But if I could do it all again, what would we do differently? I think asking public health side to listen to the animal health side more, to get that experience and to share a lot more of our resources. We all, as vets, scientists and medics, have transferable skills. They weren't transferred at all during the outbreak. We could have been more useful to one another. So I'd hope that would be picked up next. There's never a next time, but whatever happens next time.
Callum, you're a crystal ball.
So my crystal ball is to remind everybody that that COVID was not a bad pandemic. It was the mildest of pandemics, and unlike influenza, it in reality did not affect many, if any, children. And in 2009, when we had another mild one, we had 600 children die for no good reason other than swine flu, influenza. So to come away from this thinking that we would never lock down again, this should really be seen as a dress rehearsal for a highly pathogenic influenza, where we might have a case fatality rate between 0.1 and 1%, affecting all ages, with a predilection to children and young people who have not benefited from 60 years worth of past influenza exposure. And I think that has to be the bottom line. I think you said at one point, government ministers like pictures, and the National Risk Register moved from a text-based system to a picture-based system at the start of the Conservative government in 2012, because our Conservative government likes pictures, so that's true. On a personal basis, I think I went into this thinking it's going to be a rough 6 months. I didn't think it was going to be a rough 2 years, and I did not pay enough attention to my personal well-being or that of my family, particularly for the period when it stopped, and you suddenly stop being action man and suddenly find that you've got no grants lined up for the next 5 years. Sure, you've got a great publication record, but you've got no grants lined up. You suddenly find yourself without that same personal purpose. And it's a very strange place to be, actually. It's like a returning soldier. You just think, right, what do I do now? And that's caused me a lot of personal reflection. So I think, translating that back into pandemic, I think you need to think about, this is a bad pandemic or this is a not bad pandemic. How do we recover society? Because if I'm feeling this way, what about all those people that were stuck up a tower block for the best part of 2 years? What are they feeling? And I think that effect on society will make it much harder for society to react to the next one. And we've had a pandemic roughly every 27 years, not a bad one, but yeah.
Okay, I'm happy to open questions to the floor if you've got something you want to vocalise yourself and say. While you're thinking of the question, I'm going to point at Chris and ask Chris, because everyone's mentioned PPE, right? And Chris, I know you were in the front line of that as much as anybody. To me, it looked like you were all working on Ebola, right? Now, I can make it sound like I was in West Africa. Callum was actually there, and we, in my lab, very nicely got nice, clean RNA that was non-infectious anymore and all the rest of it. But do you think you needed all that PPE, or would some type of proper mask have just been good? Because after all, it was just a respiratory infection. So I'll do that while you think of questions for the panel, or victimising poor Chris here.
Yeah, absolutely, Julian. So I think one of the things that I commented on to a few people yesterday is that in my talk, the slides where we were all wearing masks was very clearly not at the start of the pandemic, because at the start of the pandemic we had 0 PPE. And I remember doing a ward round with Ahsan Akram, who's one of my academic colleagues, very early in the start of the pandemic on our clean non-COVID ward, and we saw case after case after case of young people with cough, fever, respiratory infiltrates. And we went around every single one and said, these people all have COVID, even though they've not yet tested positive. And I think that even within a healthcare setting, we were actually very late to get appropriate PPE out with intensive care areas. And I think, rightly or wrongly, PPE was very much prioritised for certain areas in the hospital, but not others. And I think that that had a really dramatic effect on well-being and health of the staff that were looking after people out with very hot zones. You know, I think in respiratory medicine sometimes we're slightly blasé about wearing masks, and we'll, you know, wear a proper FFP3 mask if we think it's tuberculosis or something else. But I think a lot of the rest of the time we've gone back essentially to normal, to not wearing PPE for routine procedures. Exactly what all the lessons are in between all of that, I'm not 100% sure, other than I think when there is, at the start of the next pandemic, hopefully we will have a reasonable amount of appropriate PPE that is widely available to the medical community and not just prioritised to very specific hotspots. So I don't know if that's in any way, any way helpful, or just a slight rant.
Yeah, no, that's... So then on that subject, because you can also answer this as well, in terms of resource. So Peter, you were saying the first question you asked the President, I guess, was how many beds have we got? Yes. Can you elaborate?
Yes, when I asked, I was told that we have 12 beds in full operation in the general hospitals, and possibly another 8 in the private hospitals, which at that stage they were not part of the system. And of course, with 8 beds, who are you going to save? You know, we would have been in the same situation as in Italy, where people were dying in the corridor. To me, that was unacceptable. And of course, after the first wave, the government was very quick to act. And by the next wave, we had 120 intensive care beds because we got respirators from China, which opened in the meantime. And the PPE, the necessary PPE, and then there were wards on all the hospitals on the island. We went up to 350 acute COVID beds in the whole of Ireland. And I must say that during the Delta exacerbation or wave, we reached 72 people in intensive care and 315 hospitalizations. That was the highest we ever reached. So we were within the limits It was touch and go whether to go for lockdowns if we surpassed that number. So we played it safe, it worked. We got the Europeans congratulating us for coping so well, but at an expense to the economy of the country, social problems, husbands beating wives. We had a lot of issues like that. And of course, people ringing saying, I'm going mad staying on the veranda of my flat. And I used to say to them, why don't you go down and go around the block? You can do that. It's not prohibited. Just get out for a while, provided you don't meet any other people.
So on that side, I'll go to Chris and then I'll ask the two of you individual questions. But Chris, when I gave a seminar on coronaviruses up in Edinburgh in February 2020, and it was Paul Diggard who invited me up, and it felt like, this was the last time I'd seen him in a long time, which it was. I was speaking to Kenny Bailey, Callum's colleague, the ISRIC czar, and I said to Kenny, if this turns out like pandemic flu, which is what we were kind of thinking by that point, it'll be an infectious disease clinician probably. He went, no, it won't. It'll be an intensivist problem. And what was your experience then of all of that?
Yeah, so it's maybe worth expanding that actually, certainly in the UK, the vast majority of deaths happened out with intensive care facilities, and even within a hospital setting, the vast majority of patients were getting looked after out with intensive care settings. So I think there was rightly a lot of focus in making sure there was adequate intensive care facilities and ventilation capacities, in the expectation that there was going to be large numbers of patients. But I think at one stage in our hospital we had more than 10 patients with severe COVID on a respiratory ward for every one patient that was ventilated. And maybe just to follow up on what you said about keeping within capacity, and some of the comments you made in your talk about were the lockdowns really totally necessary. I think certainly within my little ecosystem and locally, although we massively expanded capacity, we always kept within that expanded capacity, but sometimes it was very, very touch and go just how close we were to being utterly and catastrophically overwhelmed, and at more than one time point. And very clearly this was happening all over the UK, not necessarily completely coordinated, because there are local factors that influence case rates. So again, we largely kept within our expanded capacity, but sometimes it felt very, very uncomfortable as to how close we were to being truly overwhelmed.
Thanks, Chris, and thank you, Peter. So question to Helen then, related on capacity and bringing in the animal side now as well as the human side. What capacity do you think we would need in an ideal world for disease X, should it emerge, either in the animal world or in the human world or crossover? What do you think our baseline should be in terms of numbers of PCR tests per week? And that's a loaded question to you because you mentioned foot and mouth.
Yeah, so we do have a process for something called the National Security Risk Assessment, where we have modelling that looks at the likely worst case scenario for, we've actually got 4 different diseases on there. So we've got African swine fever, African horse sickness, foot and mouth disease, and highly pathogenic avian influenza, not a zoonotic strain. And that tells us that we should expect to see, for FMD, for example, roughly half of what we actually saw in 2001, because we think we've now got better controls in place. And we have a committee called the Disease Emergency Response Committee, whose job it is to make sure that we've got enough test kits, because these infections don't happen if you're expecting 2,000 infected premises plus the related surveillance you have to do to regain disease freedom. It's not going to happen in a week. That's going to be over a 6-month period. So you just need to be able to build it up, but you have contingency stocks of things. what we were asked at the beginning of COVID was how much of our stock we could give over to the public health sector. So PPE, which we always have a stock of, we were handing that over. And we were also doing our own modelling in terms of thinking, well, if we get the worst case scenario for COVID, and SAGE was providing those numbers to us very, very usefully, what does that mean for our sector? And actually, when you look at the average age of the British farmer in the UK, they are 60. So most of our farmers were falling into that high-risk bracket. And that was really worrying us, that you're going to have a population that would be really taken out by COVID, and therefore you've got all the knock-on impacts in the animal health side, particularly around not being able to do any bovine TB testing. It might sound a bit trivial, but when that happened in 2001, we were at a nice steady low level of bovine TB before that. After 2001, it zoomed up. It's never been we haven't been able to bring it back down again in any sort of rapid progression. So we would be looking at those sorts of things, trying to estimate constantly the numbers. And interestingly, while all of this has been going on, we have gone through avian influenza in probably, a slightly longer time frame, but with the same number of reasonable worst case IPs or infected premises that we would expect in the reasonable worst case. So we've had hundreds of avian influenza outbreaks in the last 3 years. And we have coped, we have managed with that, even working remotely as a disease control team, not being able to meet up because of COVID. So we think we would probably be okay. There will be an issue around staff. That's going to be our biggest problem. Having enough vets to go out in the field and take the samples, because the legislation means they have to be vets. They can't be auxiliary staff. So that will be the limiting factor that we have. And we then have to go back to the vet schools and do a special thing through the Royal College to get them to come in.
So, go on, Peter, yeah?
The thing that worries me about the avian influenza virus is that we as humans do not have the appropriate receptor. So the few people that get infected, we're at a dead end at that stage. What worries me is the transmission of the virus, the recent transmission to cattle. It's a mammalian animal. It seems that it had to change slightly the binding to the receptor to infect those animals. And sooner or later, because we are in quite close contact with cattle, the virus may adapt to us too. And that's what worries me most. And I think that might be the next potential pandemic. But the older amongst us have some sort of immunity. I'll go back to what Callum was saying about the young children who have no immunity. I know in Cyprus they're not immunized by their parents, so we will have a problem there.
So I've got a question for Callum on this sort of immunity area. So quite rightly, he put, in actual fact, COVID was mild. The other virus we work on is MERS, which is really, really bad. And one of my friends at Bristol said, imagine if COVID had the death rate of 1 in 100 children rather than 1 in 100 elderly. People would have taken lockdown measures and social measures very, very, very differently. So, Callum, my question to you, and I'll preface it, is I knew we were going to be okay and I was saved for two things. One, when you presented COSIN data at NervTag showing that the incidence of the admission of elderly to the hospital had basically disappeared with vaccination. And then when James ran an animal model looking at how one variant protected against the next variant, and then he thought, actually, if I get this, or I get a vaccine, I'm going to be fine. So just to be a little bit provocative now, thinking of the economy, do you think we should have vaccinated the working age population first to get people back to work and the economy going, or do you think we did it the right way round? Purely hypothetical, not Professor Semple says.
It's a really interesting ethical debate about the value of life. And
My parents would kill me now if they
and
saw
when
me on this.
And I was actually put on the same spot in a live debate with Lord Jonathan Sumption. For those of you who don't know, he was a senior appeal
Court
courts
judge, yeah.
judge. And his attitude was that the value of life, to paraphrase, the value of life diminishes the closer to your likely point of death. And that view was found to be objectionable by the majority of people that heard it, because essentially it's saying that your value of life diminishes. Not only that, but he also felt that the value of your life diminishes if you've got ongoing medical conditions. So me with high blood pressure and dodgy cholesterol and perhaps some pre-malignant changes, my value of life is less again. So I think if you take that argument, it's a very, very slippery slope argument. So I think no, saving life is paramount. There should be no point in saving life when that life has got to a futile point, but that might be a futile point because your SATs are in your boots and you're already in hospital. But no, I think the principle of saving life is valid. I think where we got the messaging wholly wrong in the UK, and this probably will stop me getting a government job,
You can join Helen in the dole queue on Monday.
Well, we gave out a message of protecting the NHS. That gave the wrong message. It made a dichotomy between, or polarization between health and economy. And it would be much better if we said save lives rather than protect the NHS. Because in reality, and I'm not James Bond, but I do have a very big interest in the other stuff that goes on. And the reality is that if you can't reduce pandemic impact, you cannot then put a fire brigade team onto a fast jet runway to allow a fast jet to get above the North Sea to intercept a Russian jet coming over. And that's the reality. So it's not just about protecting the NHS, it's about putting fire crews onto runways, it's about putting specialist armed protection teams of police and counter-terrorism teams into Liverpool against organised crime. And all these things were actually damaged by the pandemic. So to say, oh, we're just protecting the NHS, fails to transmit to the population that we're protecting society. And it's not a polar issue between health and society and economy. It's one big, complicated ball of string of interactions, and that's why we took our actions. So I think that's a long way of saying no. I think Chris Whitty was right to go for the high-risk groups starting the way down, with some exceptions for healthcare workers because they put themselves directly in the line of fire. I think it'd be really interesting if we get an outbreak, we would start to see poultry handlers, gamekeepers coming down with something, wildfowlers coming down with something, and then we think, right, who are we going to vaccinate now? Because actually, we would need to target our poultry workers. We would need to target our poultry workers and our people like that. That's a slightly harder one to do.
Yeah.
Volker.
So I fully agree. I think what we underestimated is the societal impact of a pandemic. So we were discussing now a lot of biomedical things, but it was already mentioned, for instance, communication. And I think if we think about the next pandemic, how it will be more important, or even more important, how we act as a society. Not only focusing on the biomedical problem, but also keeping the society healthy in terms of that we can live with each other in the future. And I think you asked in the beginning what went wrong or what would you have liked to do. I think if we talk about communication, we also have to think about media. And I think this is maybe a thing that happened in many countries. There were experts on TV that had no idea what they were talking about. And so one thing is to communicate what the government is deciding, but the other thing is also to prevent that people stand up and tell bullshit.
Christine, no, that's right, Volker. I mean, I think in the UK, I mean, it's quite a good idea, but we had the Science Media Centre, and they would email out hundreds of thousands, I guess, of at least hundreds of people going, there's this, and this, can you comment? And then you get some like bacteriologists, not to denigrate any bacteriologists, but, you know, talking about, oh yeah, this virus, or even virology colleagues actually, this virus won't change. And you're like, it's a bloody coronavirus, right? It's going to change. Or they've read, well, it's got proofreading. It's got proofreading, but that proofreading still keeps it at a level of mutagenis equivalent to any other virus. And I shared that frustration at the time.
It's
go on.
they
Oh,
have
okay.
the levels, so they move them as you start talking.
There we go. There's another area of that which is a problem, which is where do people get their news from? And these days, the younger generation get all their news from social media. And they believe the things that have the most number of likes. And those likes can be, ha ha ha, isn't that funny that you'd be saying that, as opposed to, completely agree, you're absolutely right, the science is correct. And that is a real danger that's going to, I mean, hopefully, maybe the bubble will burst, and maybe people will go back to reading newspapers, listening to television. Yeah, we're all shaking our heads there. And somehow we've got to get better at communicating on social media to people of all generations about the science and the evidence and so on, I think. And that's going to be our tricky bit, because we're all a bit nervous of, I don't know how to use Facebook.
Oh, you're so been and gone. My kids would be looking at you, with scorn, Helen. They said to me, I don't even have social media, but their mother does, and they said, oh, Mum, that's like last generation. Everyone's on Insta or TikTok or whatever it is now,
God.
Christine, go on.
So, an interesting thought that always goes through my head, and if anyone has ever played Pandemic, the board game, it does feel like SARS-CoV-2 has done so many things right to do the best spread ever. And like Callum's comment, right, if it would infect children, if it would have been more lethal, the reality is everyone would comply. If it would infect children, no parent would go out and put their child at risk. But if you kill out the elderly, if you're mostly benign, people just get this blasé attitude and actually are not complying, and they're doing many things wrong so that the virus is massively successful. Also, spreading asymptomatically. Brilliant idea if you're a virus that wants to spread. So I'm wondering, it's probably not going to happen in this same attitude again. And what's going to happen, right? In my book, as a government in pandemic preparedness, you cannot win. Because if you do everything right, you have expenses and you damage the economy inevitably, but nothing happens. And people will tell you, we've had all this expense, we've wrecked our economy, and nothing happened. Next government, who is going to be like ours, that we just had. What do you think?
So I guess to paraphrase that, what's the preposition? If what I think it was Callum said, once every 27 years, or basically it's once a generation, isn't it?
Yeah, I totally agree. It is, we're stuck between a rock and a hard place. You either prepare for the pandemic, or
You don't.
actually you prepare for the epidemic, because it doesn't have to be a pandemic for it to have a
Yeah.
really serious impact on the country. And as I said before, some of our biggest problems are not having the staff to do it. You can always stockpile PPE. Okay, it goes out of date, you might have to redo it, but the cost of doing that is relatively small in comparison to employing enough people who will have a job in the off chance that in 10 years' time we'll have a very serious epidemic again. And that's where we will always have a difficulty, as well as the vaccine development. And the vaccine development is an interesting set. So much better with the mRNA vaccines, great. Whereas some of the other vaccines where you need to grow up enough antigen that you could never have you've still got a 6-month lead in, even if you've got the right antigen. And having those vaccine banks are very, very costly. We have them for foot and mouth disease, for classical swine fever, and for lumpy skin disease. They are very costly to keep, just on the off chance that one of these diseases is going to turn up. But it's our insurance policy. And we have to just convince Treasury that that's what we need. And luckily they listen, but I'm pretty sure we will. I think H5N1, we've just done a lot of the trials in Europe with France, Netherlands, Hungary and Italy vaccinating. So I'm on the EFSA Animal Health Welfare panel, and we've just today produced the second part of our opinion on that, looking at what surveillance you need to do around vaccinated flocks. It will come, definitely. The difficulty will be how many other species you have to do it for. Are we for cattle, for humans, etc.? But once you've got a backbone and something that works, then you should be able to get the safety data.
So then a question I would have is for both Cyprus and the UK is, what do you think we lack in capability? So one of the things that astounded me is that in the UK, we can think of a vaccine, we can do small-scale testing of vaccine, we can even sort of manufacture it, sort of-ish, not really, but we can't make any needles and we don't make glass vials. They're all made in southern China or wherever. So I guess to sum up then, to think of also the cat coronaviruses or just disease in general, but it's got to be coronas because this is a corona network. Starting with Peter, resilience. What would you do for resilience? And then Helen and Callum.
Well, all I'm going to say is that we are a small island. Our manufacturing capabilities are restricted, particularly when it comes to sort of from vaccine development and production. We have a couple of pharmaceutical companies, but they just produce tablets.
You're reliant on the nasty EU, aren't you?
Exactly. We are reliant on other countries. But what I will say is that the government here supported financially small businesses and big businesses at the time of the pandemic by partly subsidizing people's salaries. So the economy, when things went back to normal, it just took off. It didn't stagnate. And you can see that Cyprus has got...
You got no potholes. We have lots of potholes. We've
we
noticed
do,
that.
in some side roads we do, yes, but not in main roads. So I think in our case, what we need to do is be ready on the health side of things, the hospitals be ready, have trained people, particularly nurses, because at that time we had hardly any intensive care nurses, and they had to be trained very quickly over a summer period. So training, having the PPE, which we will need to replace every so often because they go out of date. But we must be ready in that respect as far as Cyprus is concerned.
So, Helen, resilience for you then, in the animal side, crossover to human.
So resilience, it's almost also flexibility and preparedness. So for me, there's lots that we can be doing as preparedness that would give us the resilience. Building networks of people, understanding that transferable skills, sharing data in peacetime, having, I don't want to be cheesy or anything, but having research networks like this, where you've got international collaboration and you've got really good sharing of data, and therefore in wartime, as it were, during outbreaks, those relationships are there already. So you know who to go to, who to speak to, what to do, learning from each other, sharing experience, equipment, what have you. Remembering that when something new and emerging starts out, we have so many evidence gaps that you can't expect one academic partner to do it all and to get all that information out. You have to do it through partnership. So sharing that data, I think, is really important. And the resilience side will grow from that. And we do have a lot of surge volunteers in government So particularly DEFRA, people talk about the AA being the fourth emergency service. We think of ourselves as being the emergency department because we deal with floods, we deal with CBRN incidents, we deal with animal disease and plant disease and fisheries and so on. Those people should be able to work for one another, and that will give you more resilience as well.
Thank you. Callum, last words.
I think we need to go one level higher. I think we need to get our mutual governments to embrace having scientists embedded within them as part of their usual activities, rather than the top humanities and top lawyers from universities going into government. We somehow have to get science, and not just BSc graduates. We need to get a pathway in for masters, PhDs, and professors even, to get into government more easily, so that the culture changes towards being evidence-based and also understanding what the difference between an antigen test and antibody test, how does resistance happen, why can't you grow a vaccine quicker? If we got some solid science into government as much as we have arts and humanities, I think that would give us greater resilience in the next 20 years.
Thank you, Callum, and that's the exact point that Stavros Malas made to me yesterday about science and politics and how they intertwine. So I'd like to wrap up now by thanking our panel. Thank you for staying till the end and your questions. I'd like to thank Lisa and Jill for their organisation and getting us all together. I know they always roll their collective eyes when I say, "Hey, I've got this good idea for a meeting." And finally, I'd like to thank the University of Nicosia, but also acknowledge our funders who paid for this. So this is BBSRC and DEFRA in the UK for funding our network and having the foresight to facilitate this type of network. So we've got half an hour break and then we're on our cultural tour of Nicosia. So thank you, everyone.